much for the introduction, and I take it you can all see my screen okay? Can you
Yes,
see my screen? Yes, okay, excellent. So I hope that this talk will actually answer a lot of the questions that are in the chat or in the question and answer session. I will, without further ado, jump in. And so the focus here is going to be talking about the complications and adverse effects of high-frequency ventilation, and to talk about how to avoid those, and a little bit more about volume-targeted high-frequency. So we've made this point before, but it bears repeating because it is so important. Ventilators are tools in our hands. There are no magical ventilators. They're not all, the ventilator itself is not inherently lung protective. Certainly some ventilators are better than other, or can do it better than other, but only if we use them with optimal thought process as to what the underlying disease process is, what size baby, how old the baby, and all the other things. So it is up to us to really understand the underlying concepts. So like anything, high-frequency ventilation has potential complications, and some of those are the same ones that apply to conventional ventilation, of course. And there's been a lot of concern about hemodynamic impairment for high-frequency ventilation. I would argue that that's really preventable. It's not inherent in oscillatory ventilation. And I will explain why I believe that. Respiratory alkalosis has been a recurrent problem, and it is because of the power of the high-frequency devices that we initially used, the sensormatics, for example, but also because of the rapid changes in lung compliance. Of course, that alkalosis is related to brain injury. Air trapping has been a concern, and air leak and potential lung injury have also been problems. Early on, atelectasis was a problem when babies were muscle relaxed and inadequate mean airway pressure was used, but that problem has pretty much resolved. So again, we all have these tools. Some have many of them, some only have one, and we really need to know the limitations and the strengths of our devices and how to optimally put that particular device to work. It is also important to understand how inspiratory-expiratory ratio, or percent inspiratory time, impacts on pressure transmission from the circuit into the baby. And so there is this rule of thumb that you increase the pressure by 2 centimeters with a 1:2, and people don't recognize that that actually only applies when you use a 1:2 IE ratio. And so what this graph shows from an old study by Ulrich Thome is that with a 1:1 ratio, there was not much difference, but if anything, the circuit pressure was a little bit lower than the pressure in the baby. With the 1:2 ratio, there is a gradient, and this has been shown also by Jane Pillow. There is actually a gradient between the circuit and the trachea, and this has to do with the fact that with the asymmetric velocity profile, it takes less pressure to exhale because you have a longer expiratory time. So when you actually, so the measured pressure in the trachea typically is a couple of, mean airway pressure is a couple of centimeters less than what you measure in the circuit, so that actually going up by 2 centimeters merely compensates for that change. This study also looked at other ventilators that were not really true oscillators. The baby log is sort of in between. The infant star very much was not a true oscillator, and you can see there was a lot of air trapping going on in that study, even at low frequencies with the infant star, and certainly when with both devices, the baby log and the infant star, at very high frequencies. So again, knowing the performance characteristics of the device is probably important. This point was made, so the next issue in terms of the optimal lung volume strategy, you saw this graph presented by Anton van Kam already. And again, it emphasizes that the lung protective effect of high-frequency ventilation is related to both the decreased amplitude and tidal volume, but also to optimal lung inflation and even distribution of that tidal volume throughout the lung. When the optimal volume strategy was not utilized, as in this middle graph, you can see that the lungs were quite severely damaged despite the use of high-frequency ventilation. So important to always make sure that we do that. And this is just another look at how lung recruitment occurs. And this is now kind of moving. So we're starting with a relatively allostatic lung where there's going to be regional damage to the lungs from regional over expansion. When you're starting on the inflation limb, compliance is poor. You progressively increase stepwise your mean airway pressure, as Anton described. And then eventually you get to when the lung is fully open. And when that happens, you're actually significantly overexpanded in some portions of the lung because there are pressure, there are gradients that are dependent on gravity. So the apical portion of the lung is more compliant than the dependent portion of the lung. So you don't want to stay here because you will have overexpansion. You will have impeded cardiac output. And in the old days of high-frequency ventilation, once we recognized the importance of the open lung strategy, the dictum was increase the mean airway pressure. And when you found, quote unquote, the right pressure, stay there. We didn't wean. And that was a mistake because, of course, once the lung opens, the alveolar radius increases, and we know from Laplace's law that the lung becomes more compliant. So you don't want to stay here. This will cause trouble. You need to then slide down the expiratory limb, as he explained, and find the sweet spot just before the closing pressure. And this is where you want to be. You want to be adequately inflated, but not overinflated. So this is important again. And this is what we did for many years. And this is where I think the oscillator acquired a somewhat undeserved reputation for routinely impairing cardiac output. That does not happen when we use the appropriate lung recruitment strategy. I will share with you a little vignette of a clinical scenario that I came across with one of our very good fellows. This was a little 24-week, 600-gram, a very small baby, was status post antinyl steroids and surfactant, was intubated in the delivery room because of the size and inadequate effort. Started on SIPPV or assist control, modest settings. Initially was not oxygenating well, required 100% oxygen. So these low settings were escalated to 24/7, still not extremely high, but the baby continued to not oxygenate well, and was therefore switched to high-frequency oscillatory ventilation because that's what we typically do. That's what everybody typically does when oxygenation is a problem. And blood gas was obtained, and it wasn't very good. Still requiring 100% oxygen. There's CO2 retention. And there's some base deficit. And so one might wonder what the next step would be. Whoops, this happened too fast. So the tendency, of course, would be to increase the mean airway pressure, maybe increase the amplitude as well because of the CO2 retention. And I use this in many of my talks. And the correct answer is it depends. Because we haven't shared all the information. Well, I did inadvertently. So this is actually the X-ray of the baby before initiating oscillatory ventilation. So this was still unconventional ventilation. This baby had no lung disease, or minimal, immature lungs, but already treated with surfactant. So more is not always better. We need to, and this is to Anton van Kam's point, is if you start too high, you might be overexpanding the lungs. So we need to be careful. And certainly this baby had hemodynamic impairment. That's why there was a base deficit of 9 an elevated lactate. And indeed, the other point to make is that one of the options was increase amplitude. And I told my fellow, no, actually, you need to decrease the amplitude. After you drop the mean airway pressure by 6 centimeters, you will also be dropping the amplitude because you're now overexpanded. You're on the flat upper portion of the compliance curve, and the lung is now stiff. And the compliance will improve once you deflate the lung, and that's indeed what happens. So this is an important concept, that if we have excessive mean airway pressure, excessive distending pressure, we are going to have multitude of effects. We certainly adversely affect lung compliance. We decrease pulmonary we decrease pulmonary blood flow because the pulmonary vascular resistance is increased. We also decrease cardiac output because of impeded venous return systemically, and potentially increase the risk of intracranial hemorrhage by impeding venous return from the head. So it's really important that we always seek to find the lowest distending pressure that will maintain lung inflation, but avoid overexpansion. And if we do that, we can avoid these complications. These complications or adverse effects are preventable, but not clinically somewhat challenging. So these two studies have been mentioned a number of times, and everyone has remained quite concerned about why the difference. And I agree with Anton on the point of this last point being really important. In fact, the so-called severe lung disease that he mentioned was these were the thresholds that defined severe RDS. I would argue that's not very severe. So the severity of illness, I don't think, was appreciably different. But what was different was the devices used, the ratio that was used, and probably this was very important, that the babies did not stay on high frequency long enough. But let me again get back to that study by Ulrich Thome, where they demonstrated that with a 50% inspiratory time or 1-to-1 IE ratio, the alveolar pressure was higher. In other words, there was relative air trapping than the pressure measured in the trachea here. With shorter inspiratory time, the usual 1-to-2 or perhaps even 1-to-3 IE ratio, the pressure distally was lower. And this follows from simple fluid mechanics, where if you have an equal time to push gas in as is needed to suck it out, the pressure needed to do that will be the same. If you allow twice as much time to remove that same volume of gas, it will take lower pressure gradient. And so this explains why under many circumstances you can have problems. And then this will be exaggerated if you are not using sufficient distending pressure. If you have relatively low mean airway pressure and you're sucking air out of the airways vigorously, you're going to collapse the small airways and cause air trapping. So this is to the point of some of the problems reported in the meta-analyses regarding air leak. And again, I don't believe air leak is an inherent problem with high-frequency ventilation, but if you're using a 1-to-1 ratio with a low mean airway pressure, as was the case in the HiFi trial I mentioned earlier, then you can cause some serious problems. We're all ganging up on the authors of the Vici trial, but it was a really egregious example of how not to use oscillatory ventilation. And they came up with what I am convinced, and most of us knowledgeable in the field are convinced, was the wrong conclusion. It was, and I'm just showing you some specifics. We know that hypoplastic lungs, hypoplastic lungs should not be aggressively recruited. We know to use a gentle strategy with low end expiratory pressure, and that's what they used in the control arm. However, in the HFOV arm, they used what is a strategy that's appropriate to severe RDS, but is not appropriate here. They started with a mean airway pressure of 13 to 17 and a high amplitude. And not surprisingly, they did not only fail to show benefit of high frequency ventilation, but as Anton explained, all of these adverse effects, which clearly all center around overexpansion of a hypoplastic lung, which we know worsens pulmonary hypertension. So again, it just emphasizes the importance of using the right strategy in a given population. It's a tool that needs to be tailored to the underlying disease. And the underlying disease that best responds to high-frequency ventilation is a disease where the time constants are short. Small babies with RDS. What are time constants, you may ask? Time constants is the concept of how rapidly air gets in and out of the alveoli. So small babies with low compliance and normal airway resistance have very short time constants and are optimal candidates for high-frequency ventilation. Older babies with BPD, I don't ventilate with high frequency because they have long time constants and they're not particularly suitable, and there's no demonstrated benefit in that population of HFOV. So when we think about using oscillatory ventilation, we need to, who is your patient? What's the size, postnatal age? What's the disease process? Is it a big baby with meconium aspiration? Long time constants is going to need lower frequencies. Is it a baby? My goodness, my thing is running away for some reason. Certainly, lung volume recruitment is appropriate if we think we're dealing with recruitable lung disease, and you heard all about that, but it's not always the right strategy. Avoiding overexpansion is critical, as I pointed out. And I think what's important to emphasize is that the optimal distending pressure today may not be the optimal distending pressure tomorrow, or not even tonight. So we need to reevaluate. And as Anton pointed out, it's important to attempt to wean the mean airway pressure periodically, at least daily, if not twice a day, in order to get the baby off mechanical ventilation. And by the time the baby's 2 or 3 weeks old and the disease process has evolved away from RDS, I typically switch my babies back to conventional ventilation, all with volume guarantee, of course, because there is, and usually they do better immediately and require less distending pressure when you change to conventional ventilation, because this tool is no longer particularly, meaning the oscillator is no longer particularly suited for treating babies with evolving chronic lung disease. Again, I already mentioned this: wean, and again, avoid the compromise. So this is some of the generalizable advice that I wanted to address some of the concerns about complications. And everybody used to love the Sensormedics oscillator, but it is an antique. It belongs in a museum, and it was designed for babies with different lung disease, pre-surfactant, effective conventional ventilation, limited use of antenatal steroids. And it has no monitoring. It will tell you what the mean airway pressure in the circuit is, and that's pretty much it. It doesn't provide any patient information. And again, it is very powerful, and we need to remember that, again, it's tidal volume squared, right? So even small changes in tidal volume can result in dramatic changes in CO2 elimination and lead to hyperventilation. And we also need to be aware of the fact that compliance can change quite rapidly in our preterm infants. That is why, and as Emmanuel emphasized, too much horsepower may not be a good thing. I will give you one egregious example of how high-frequency ventilation used the wrong way can cause tremendous damage. This was a study published back in the 1990s using a jet ventilator with the wrong strategy. where tremendous hyperventilation occurred, and predictably there was lots of badness going on with cystic PVL. Death IVH or PVL combined were more than double in the high frequency population. But look what was happening with the pH. So tremendously high PCO2 and I'm sorry, low PCO2 and high pH. So it's important to know that throughout, and I mentioned in my first talk, throughout the history of high frequency ventilation, there are a number of studies that have demonstrated how inadvertent overventilation can occur and how it can lead to very bad outcomes. And this is why I am very excited about high frequency with volume guarantee, because it removes the one major concern that I've had and many have had in terms of using high frequency ventilation with a low threshold or as a first line treatment, because of the risk of overventilation, because they're so powerful, and the consequent adverse effects. So we'll talk. We'll circle back to volume guarantee, but I just want to address the other problem, which was air leak. Which so I think one of the other studies or the data from the same meta-analysis that Manuel showed was any air leak, which included PIE. I focus more on the gross air leak, which is more unequivocal, because I find that PIE is often overdiagnosed. Nonetheless, so in this instance, while the point estimate favors conventional ventilation, gross air leak did not reach statistical significance. But notice that it was really a handful of studies that drove this increased incidence, and that was the study of Ulrich Thome, which was an infant star flow interrupter, and a few other studies. This study was done with the Babylog 8000, a very small number, really. So it is probably not, again, inherent to oscillatory ventilation. It does not occur with a 1:2 IE ratio, 30% inspiratory time. And it does not likely occur when we have automatic weaning of pressure amplitude and avoidance of volutrauma from excessive tidal volume when we switch to a volume guarantee. So again, emphasizing, we keep repeating it because it is so important. You need to know your device, know your patient, understand the underlying pathophysiology, and use the right strategy for that particular pathophysiology. Be careful to avoid overexpansion, reassess the distending pressure on a regular basis, and wean when possible to avoid hemodynamic impairment. If you do not have volume guarantee or choose not to use it, always use transcutaneous CO2 monitoring. And even if you're not using volume guarantee, the DCO2 is a proxy of ventilation. It's really a calculated value for CO2 elimination. And you can therefore manually respond to changes in DCO2. But if you use HFOV VG, then the DCO2 will remain constant and you don't need to worry about it and try to respond to it. And I think Manuel has convinced us that we should use the highest feasible frequency to minimize the tidal volume. Now, so in the US, sadly, we don't yet have access to the volume guarantee option of high frequency, but we were able to do a randomized trial. So this is one of several devices that has the capability to use volume guarantee with high frequency ventilation. It's not the only one, but it is the one that I had the opportunity to work with and Manuel works with, and it works very well. And I'll show you briefly some of the advantages. One other thing, we did a small study as a baseline. The noise generated by the sensormedics, by the sensormedics is tremendous and goes way up with amplitude. I don't know why my machine jumps forward on its own. The VN500 is much quieter and remains quiet despite increased amplitude. So that's a good thing. Babies, go deaf. And this is a decibel scale. So this is a meaningfully higher baseline noise level. I think Manuel already briefly described how it works. Again, it's very much the same as conventional. Instead of PIP, it's the amplitude that's adjusted automatically. It averages over a few cycles, and you have to set the amplitude limit for safety, just like you set the PIP limit with conventional ventilation. People need to remember that mean airway pressure is still in manual control, so it's not fully automated. You have to pay attention to the distending pressure, but your tidal volumes will stay very much the same. And I think the thing that confuses people most and has been the source of the reluctance on the part of many to adopt volume targeted high frequency is that it behaves differently than what we're all used to. Everybody is used to with VG off that there is this very straight relationship between frequency and tidal volume. At lower frequencies, you get a large tidal volume, and in higher frequencies, the tidal volume goes down. This is from Manuel's work again. And the thing is, who needs tidal volumes of 30 ml? Nobody, not even for your big baby. So when you turn VG on, the closed circles, you will notice that with frequency changes, there's absolutely no change in tidal volume until with this device, you can't at frequency of 15 hertz quite generate a tidal volume of 15 ml. But again, who on earth wants a tidal volume of 15 ml? I don't. So DCO2, of course, is the product of tidal volume squared and frequency. And when tidal volume is fixed, the effect of frequency is now unmasked, and the tidal volume being fixed, the higher frequency gives you higher DCO2, again, until there's a tailing off because the tidal volume drops. So please just think of it simply as the behavior is just like with conventional ventilation. Higher rate eliminates more CO2. That's all. So with high frequency, standard high frequency, it's the opposite. Lower frequency eliminates more CO2. Opposite of conventional ventilation. With volume guarantee high frequency, it behaves like conventional ventilation. You go up on rate, CO2 will drop. Okay. Now, what about the tidal volume? You heard a lot about it from Manuel, and we'll just show you some data we gathered, or I had colleagues, this is from Japan, gather for me because we didn't actually have access to the device. And what's interesting to point out is that for equivalent CO2, you need a somewhat larger tidal volume the smaller the baby is. Just like with conventional ventilation, it has to do with anatomical dead space. So the anatomical dead space matters. So at the standard frequencies, we were talking about tidal volumes of about 2 ml per kilo in the 750 to 1,000 gram, but the really, really small babies needed, for eucapnia, needed somewhat larger tidal volume, about 2.25, and the bigger babies needed less. This is another data set that looked at tidal volume generation, and you can see obviously frequency has an impact. You need a lower tidal volume for the same CO2 with a higher frequency, but it was also a function of alveolar dead space. The sicker babies with higher oxygen requirement needed a bigger tidal volume. Older babies with evolving chronic lung disease and increasing physiologic dead space also needed a larger tidal volume. And the tiniest babies, this is not a large difference, but it was statistically significant. And there's been a plethora of small studies describing oscillatory ventilation with volume guarantee, but none of these were randomized prospective studies, and they were all quite small, but they cumulatively did suggest that it works and that it is safe. But of course, in the US, we have our Food and Drug Administration, which has to approve a device or methodology. And so in order to try to get that approval to happen, I was able to pull together basically all the folks who've done high-frequency oscillatory ventilation in the US in a major way, in a research way. And we embarked on this prospective study, which aimed to be able to convert a conventional ventilator, which is all we were able to use, to high-frequency ventilation. And we, of course, chose to use the volume guarantee because that is the biggest advance. And we used a prospective, we used a comparison cohort that was prospectively collected just prior to the initiation of this study, because all the larger published studies were almost 20 years old at that time. And so this is a cohort study, not a prospective randomized study, and we weren't happy about that, but that was a decision made by the sponsor of the study and the FDA. So you can see that these were all very immature babies. They tended to be a little more immature. There were more really immature babies in that cohort, but they were generally quite comparable. And the primary outcomes of that study were, of course, survival free of severe IVH was the primary outcome. These are the subcategories. And you can see that survival was comparable. The IVH of the lower grades was comparable, a little bit lower. Severe IVH was actually statistically reduced, but this was a non-inferiority study design. And PVL was also lower. So the primary outcome was this life free of severe IVH PVL, which was, to get rid of this if it's shading it, was good, favored the new device was VG. Survival was comparable, etc. This was the one statistically significant difference. And so overall, there was no safety concern. That was, of course, the primary focus. The device worked exactly as planned. And the really tricky and scary part of this study that we had to do was that none of us were allowed to have any prior clinical experience with this device. So everybody's learning curve with this device was included in this study. And despite that, the outcomes were very good. I was very worried about mistakes being made. I just want to show you the CO2 is very stable over a period of time, first 48 hours with relatively tight intervals. Obviously, babies were different sizes, so this is raw data. The tidal volume, and I will tell you that if I did this study today, I would have used at least 15 hertz frequency. We chose to use 10 hertz, so the tidal volumes are larger, obviously, than they would be at 15 hertz. And this was, of course, the study was designed prior to the data that Manuel shared with you. So as I said today, I would be using a lower tidal volume, but the tidal volume, again, was remarkably stable. And there was, interestingly, the same relationship between weight and tidal volume needed for eucapnia in our cohort. Now, this is just to study the babies from my institution, but the same relationship obtained. So it's interesting, despite the differences in the mechanisms of gas exchange, dead space still matters, because the smaller the baby, the larger the flow sensor dead space is relative to the baby. And finally, the last bit I wanted to share with you was, does it actually work as it's supposed to? And I will share with you that the raw data, again, 93% of the time, the tidal volume was within plus or minus 0.1 ml of the target. And 0.1 ml is the maximum resolution. A few were more than 0.1 ml below the target. And in half those instances, The problem was that the clinicians failed to increase the pressure amplitude. They did not allow the device to do what it was trying to do. When we excluded that, did a sensitivity analysis excluding those, it was basically 96% of the time, and very, very few instances where the tidal volume exceeded the target. So this volume guarantee is safe. It works. It works extremely well. It reduces the danger of overventilation and severe brain injury, which is what we all worry about. So as was noted earlier by Dr. Rajiv, that the penetration of volume guarantee seems limited. I see no good reason to not embrace a volume guarantee. I'm still waiting for our Food and Drug Administration to approve this device, but hopefully that will occur soon. So that's all I have, and I'm happy, and I think Dr. Rajiv is also available to answer questions.